Briefly about atherosclerosis, this is, built up of lipids and like inflammatory reaction with macrophages in the arterial wall, which I'm sure you guys learned about ad nauseum in medical school. And now it's not letting me. Okay. So some of the risk factors for atherosclerotic disease are predominantly like smoking and hyperlipidemia, diabetes, and like there's some genetic predispositions like hyperhomocystinemia and things like that. And these all predispose the patient to having atherosclerotic disease or peripheral arterial disease. Okay, I'm gonna have to just click on.
You can click up and down on the keyboard too.
That's what I'm doing, but it's not letting me. Yeah. Okay. Oh no, you're gonna see my notes. This sucks. Okay, I'll just do it like this. Okay, so just aside from the lifestyle limiting effects of PAD, which is that patients will have, trouble walking or eventually develop wounds or have foot pain in their legs. Patients that have PAD are more prone to having disease in other arterial beds. So just because, you may not think peripheral vascular disease is an important pathology in itself, but these patients have a much higher risk of having, coronary artery disease or, a risk for stroke. So that's why it's important to, when you see these patients, to kind of think about them having other issues as well, and why it's important to screen PAD patients. Okay, now it's not going to let me step through my slides.
I think in the
Do I just, okay. I think if I click.
Arrows on the bottom, kind of the bottom left. So like, you see where it says slide 8 of 93?
Yes, I can just step through there.
I think you can go.
Yeah. Okay, cool. Man, I feel like I've already burned 20 minutes. Okay. All right, so some of the effects of PAD itself you may be familiar with, like claudication, which is cramping pain with walking. And this is defined as it's reproducible. So these patients will come to you and say, I can only walk a block before I start to have this cramping pain in the back of my legs or my calf or whatever. And it's like a Charlie horse. And the big thing about this is it's reproducible. So it's the same distance. And as soon as they stop walking, that pain goes away, or that cramping pain goes away. The other thing that patients can get is rest pain. And true ischemic rest pain is these patients have pain at rest and their legs feel better when they hang them dependently. So they're hanging, you often see them with their leg hanging off the bed because that's helping improve blood flow to the feet. So rest pain isn't like, oh, I have pain all the time or pain walking around. It's like true ischemic rest pain is this pain that's alleviated by hanging their foot in a dependent position. And then, of course, these patients are prone to getting gangrene or non-healing wounds or ulcers. So kind of, in addition to these like physical manifestations, this is very lifestyle limiting. They get depressed, and we kind of talked about being at an increased risk of having other arterial disease, like higher risk for stroke and MI. So we can divide this into chronic arterial insufficiency and acute. So these patients may, depending on how their arterial disease manifests, it can be something that gets worse over time, which is chronic, or it's an acute event. So they had some sort of embolus to a vessel, and that causes an acute arterial insufficiency. So just going through chronic, what they may start off with is intermittent claudication. So that's kind of what you think about it. So they can walk for a pretty far distance, but every once in a while they get that cramping pain. Moderate or severe claudication, or that cramping pain in the calf, happens at a distance less than 200 meters. And then critical limb ischemia is when these patients develop rest pain or a non-healing wound. So that's how we divide the severity of chronic arterial insufficiency. And talked a little bit about claudication. So the way that this is, pathophysiologically mediated is in a normal vessel, you have this laminar flow. And when you have exercise, you have a matched demand and supply. So you're able to, provide increased blood flow when you have an increased demand, such as during exercise or walking. With a patient that has PAD or some sort of atherosclerotic lesion, they're not able to match that increased demand for oxygen and blood flow. So then they get, this mismatched supply and demand. Then they get this like oxidative stress, buildup of lactic acid and things like that. And then they get that pain in their legs. So that's what's happening with claudication. And claudication, this is a little blurry, but I like this diagram because depending on where the lesion is, you can kind of think, depending on where the patient's symptoms are, you can predict where their lesion is. So if they have, calf pain, you kind of think about it as being something, in the femoral arteries, like here. So superficial femoral artery, which is just above the calf, is where they're going to have pain. So the pain is just distal to the lesion. So somebody who has an aortic occlusion, it's really proximal. So it's up here in the aorta. They're going to have cramping pain in the buttock and thighs and calves, and it'll be bilateral. Once you get down into one leg, then you're going to see it, on just one side. Does that make sense to you guys? So like if they have an occlusion in their common femoral artery, which is in the groin, then just distal to that would be the thigh. And that's where they feel that cramping pain. What we classically see is patients that have an SFA or superficial femoral artery occlusion or narrowing. So when they walk, they have cramping pain in the calf. So you can kind of, based on their symptoms, think about where you predict their lesion to be. And then this is what the typical patient with like rest pain, I guess, looks like. So this is pain that's worsened when they're elevating the leg, or they wake up at night with terrible pain, and then they have to sleep with their leg hanging off the bed. And oftentimes when you go see these patients for a consult in the hospital, this is how you see them. They're hanging with their leg off the bed. Okay, so in the 1950s, somebody came up with a classification system for this chronic arterial insufficiency. So stage 1 was they had no symptoms, and we talked about mild and moderate to severe claudication, then rest pain, and then necrosis or gangrene. And so this is, a patient with gangrene in the foot. So this is a, stage 4 here. And that was the Fontaine classification was the old classification. Now we use the Rutherford classification. So that's what we use today. So when I see a patient in clinic, or if I see a consult, and you're going to present this patient to me, you'd say this is a Rutherford 3, critical limb ischemia patient on the basis of whatever. And so here there's grading, and we talk about the categories here. So it's very similar to Fontaine. 0 is asymptomatic, then you have mild, moderate, and severe claudication. And then Rutherford 4 is rest pain, and then 5 is minor tissue loss. You very rarely see Rutherford 6. This is like a huge amount of tissue loss. So tissue loss that's confined to the foot is minor. So we call that Rutherford 5. Does that make sense? This is like how we classify chronic limb ischemia. So now switching gears, we're talking about acute limb ischemia. These are patients that may not have underlying atherosclerotic disease, but they have something that caused a blockage to their arteries, and now they're unable to compensate for that. So what happens here is, and this can progress very rapidly, it's usually an acute embolus. So maybe somebody with AFib that threw a clot, or some sort of thrombosis. Maybe they had a little bit of narrowing, and then they threw a clot, or the clot ruptured. And what happens here is the patients usually present later when they've developed pain. We talk about the 6 P's of ALI, or acute limb ischemia. So they have this coolness, pulseness, poikilothermia, pulseness, pallor, pain, paresthesias, and paralysis. Once you get to this point, it's irreversible. So when you meet a patient that's like come into the ER and they're like, 3 hours ago I had severe pain, now I can't feel my toes, and this is an emergency. So we talked about chronic before, that was that claudication, rest pain, and gangrene, and this is acute. So the difference here is when patients have acute limb ischemia, and these are reconstructions, this is showing like an acute occlusion in the SFA here, so like compared to the other side. And what you're seeing here is the artery's gone down, but they haven't developed collaterals. So in this patient, as a contrast, this is somebody who has chronic limb ischemia. They have an occlusion here. So this vessel here is missing on this side, the SFA. but look at all these collateral vessels that have developed over time. So that's why these chronic limb ischemia patients present with this slow, first they claudicate, then they have rest pain, and then they develop the wound. And these patients that have acute limb ischemia, they rapidly degrade in it's like within 6 to 12 hours. So these patients the acute limb patients present with that pain, coolness, paresthesias, and then they progress to limb loss, okay? And that's because they haven't had time to develop the collateral. So you think about this patient, typically as somebody who has AFib, they don't have atherosclerotic disease, they just threw a clot down and blocked the artery, and now they don't have flow to the rest of the leg. And these patients have had atherosclerotic disease, they've had progressive narrowing, and the body's developed collaterals. So that's the big difference. When looking at acute limb ischemia, we talked about embolic and thrombotic disease. So typically when you're looking at an embolism, these are like patients who have had no PAD. It's usually something like AFib, and they've thrown a clot. The patients at thrombotic diseases, they've had some mild PAD, and then they develop some sort of thrombosis, and then they progress to having that ischemia, but it's less severe than these. So this is the one that's going to develop really quickly. Okay. And then again, just breaking it down by causes. Typically what you think about here is somebody with AFib, and this thrombotic PAD is somebody who's had some baseline atherosclerotic disease, and then they've had a plaque rupture. Okay, so just like we had Rutherford classification for chronic, we have it for acute. So the first stage is you have audible venous arterial pulses. They don't have any motor or sensory loss, so none of the paresthesias or things like that. And then it progresses to minimal sensory loss, more than the toes, and then profound. So the big key here is for an IR, when you get to Rutherford 3 acute limb ischemia, this is a surgical emergency and they have to get surgical embolectomy. There are some centers where you have the ability to treat a patient with 2B, where they're having a little bit more than minor sensory loss, but you have to like move quickly because they can progress from 2B to 3 really, really fast. Does that make sense? Hopefully. Okay. There's only 3 of you guys, so if you have questions, you can just stop and be very like casual about this. So just going back to who gets screened. So typically patients that are 65 with risk factors like smoking or diabetes. And if they have other signs of vascular disease, like they've had an MI, they have had, a carotid duplex showing some narrowing, mesenteric ischemia, that's atherosclerotic disease, like manifesting in the, like celiac or SMA or IMA. There's patients that have, narrowing of their renal arteries, then can get refractory hypertension, and then patients with AAA. So anybody in this category needs to be evaluated for PAD, and somebody who's of age with risk factors. These are old classification or questionnaires for PAD. And I mean, I don't use these strictly, but these are some of the questions I'll ask a patient that I'll see in clinic or in the hospital. So I'll ask like, do you have calf pain with walking? Does it stop like after you rest? How far are you able to walk? And then is it positional? Do you have to hang your leg down over the bed? Like things like that to kind of tease out what kind of symptoms they have. And then along with PAD, there are other things obviously that can cause leg pain that can be confounding. So you've heard about patients maybe with spinal stenosis, like that classic, old person having to walk like hunched over the shopping cart. And so, it's important to ask these patients questions like, oh, does this, get better when you bend forward, or do you have pain when you stand up? Or is it really this type of, claudication or rest pain? So these are, I've seen patients in clinic that are referred to me by, a family medicine doctor or somebody, and they don't really know. And they'll just refer them to me because they have leg pain, but it ends up that they have like spinal stenosis, or they actually have radicular pain. And you don't want to do an arterial procedure on somebody that doesn't need it. Okay, so then after you've kind of screened them and got an idea, we'll do a physical exam. So it's a head to toe thing. You're kind of looking, like what do their nails look like? Do they smoke? What does the clothing look like? Are their shoes worn like on one side? Do they have any wounds? And there's different types of wounds. So they can get a little confusing. We don't need to go through this whole table, but these venous ulcers tend to be exudative. They kind of have a little bit of drainage, and they get this, I don't know if you can see this kind of reddish pink around the wound. This is called hemosiderin staining. So that's from venous stasis, and that hemosiderin stains the tissues around there. So they have kind of it's like a shallow wound. It's got exudate, it's wet, and then they have this venous stasis here. So this happens all the time. I'll get somebody who the clinician thinks has PAD, but they really have venous insufficiency. So that's obviously a whole different thing that I treat. So arterial ulcers are these shallow or kind of punched out, I'm sorry, not shallow, deep lesions. So you get the feeling this is a little bit more shallow than this, and they have this kind of, they can have this like gangrenous necrotic tissue appearance. And the skin on the leg or wherever it is will be kind of shiny and hairless, and that's because of reduced blood flow over time. Then there's pressure ulcers, or I'm sorry, neuropathic ulcers and pressure ulcers, and those kind of, you get the impression of like how the patient's been in bed or laying. But the big difference is to recognize between these two. So that can get kind of confusing for clinicians. Okay, so after you've, evaluated the patient from an HPI standpoint and looked at their, wounds or whatever it is, we can augment our information with imaging. So this is just sort of a schematic of how we might think about evaluating a patient. So these are the patients that are at risk. We talked about patients of age that have risk factors or symptoms, and then we'll go down through this kind of flow chart. So the first thing that I'll do is I'll get non-invasive imaging, which is called like an ankle brachial index. So what we do here is we measure the brachial pressure and the pressure in, you can do in the leg or in the toe. And so the way you calculate an ankle brachial index is you'll divide that pressure in the foot by the highest pressure in the arm, and that gives you a ratio. And the normal ratio is 0.9 to 1.4. Anything above this, so if this pressure is really high and the ratio is higher, you kind of get the idea that the vessel might be really calcified and the pressure in that vessel is higher than the brachial artery. Does that make sense? So if the artery in the leg's super calcified, that pressure is going to be really high compared to the pressure in the arm, and so that ratio is going to be greater than 1.4. So when you see this, it doesn't mean that they don't have arterial disease. It just means that they have very calcified vessels. And then this is normal. And then when the pressure is really low, it means that their calcified vessels or their disease within their vessels is so bad that the pressure is low. Okay, so then that pressure is low compared to the brachial artery, and that's where you get a decrease in the ratio. So depending on this ratio kind of gives us an idea of how severe their PAD might be. Does that make sense to you guys? Okay.
Does the Rutherford scale take into account objective numbers like this, or is it pure clinical presentation?
Great question. I don't know if I can go back on here. Let me see if I can just show you quickly. So yeah, the Fontaine classification was just subjective. It's a really good question. The Rutherford classification actually takes into consideration objective data like brachial or like pressures and ABIs. Okay, so depending on where these patients' ankle brachial index falls, kind of helps us triage them. So if they're, if it's greater than 1.4, we think that might be calcified. We may evaluate them further with duplex imaging. If it's in this normal range, we kind of screen them for other symptoms. And then if it's less than 0.9, that's where we think about it being abnormal and they have PAD, and so we might get other tests. And this is just showing you how you measure toe pressure. So if you can't get a good ankle pressure, you can use a toe brachial index similarly. We also do imaging in terms of CTA, MRA, and ultrasound. CTA is, it's fast. It gives us a lot of information about anatomy. The problem is when you have really calcified vessels, it's hard to tell the difference between the calcification in the vessel and the actual artery, like the actual contrast in the vessel. And that's where MRA can be really helpful. It actually helps delineate that much better, but there's a lot of issues with MRIs that take a really long time. Patients can be claustrophobic. If they have renal insufficiency, you worry about giving these patients gadolinium or the MRI contrast, because then they can develop something called NSF. Ultrasound is great. It's, it doesn't have any radiation. It's fast and inexpensive. But the problem is you have to have a place where the techs are really skilled at evaluating. So it's really like tech dependent. And, if they can really evaluate the vessels. And then the problem is on obese patients, you can imagine if you're looking at the iliac vessels, like in their pelvis, and they have a huge pannus, you're not gonna be able to see that. So it's usually we're looking at the vessels on the groin down, or in a skinny person, we may be able to see iliac vessels. So this is a MRA, and this is just showing you the detail that you can see. And here's where you can see the calcium in the vessels too. And this is an angiogram just showing you what that would look like when we actually brought the patient into a procedure. And then this is typical images from an ultrasound. So up here, oh, this is weird. It pasted like multiple times. Okay, whatever. So this is a patent vessel here. It's got flow through the entire vessel, and it has this triphasic waveform. This is a normal waveform in an arterial vessel. What they're showing you here on the duplex here is that there's flow through the vessel here, and here there's no flow. And you can kind of hallucinate that this bright part is calcium in the vessel, and then the waveform is diminished, and there may be some reversal of flow here too. All right. Any questions so far? I was going to show you guys a case. You don't have to. It's not like a case that you're going to have to take. So, any questions so far before I move on?
So how does kind of like acute chronic peripheral artery disease like complicate like how you're? I mean, I'm assuming a lot of these patients, they got like a plaque somewhere in their vessels, like rupture, but like their vessels are so like full of cholesterol in the first place, and difficult to get through. Like, how does that affect your clinical?
So that's a good question. When somebody's just coming in with acute limb ischemia, and I don't have to worry about a ton of like rocks and calcium, it's easy for you to put down the wire and balloon or get out whatever you need to. When they're really calcified, you have to be much more careful, because anytime you put a balloon or a stent or something down, there's a likelihood that you knock off some of that calcium and it goes distally, and it can embolize and cause worse damage to the leg. So when you're working with somebody who has really severe PAD, you just have to be much more careful. You have to be really careful moving the wire through the artery. You don't want to knock off anything. You want to make sure you're like staying within the lumen and things like that. So just like from a technical standpoint, much more challenging.
Like, going off of that, is there any cases in which you would like prophylactically put like some type of device that catch any type of cholesterol with like emboli that?
Yeah, there are devices they're little baskets that you can put in, and they can catch any distal emboli. People use those when they do atherectomy, which is a type of procedure where you shave off the calcium within the vessel. So you can imagine if you're going in with a catheter and you're shaving calcium off the vessel, the blood flow is going to move it distally. So you have to have something there to catch it. And you can do that. It shaves off the calcium with either a metal device that rotates or with a laser. I don't do a lot of atherectomy, but And I don't really use distal embolic protection with angioplasty or any of the other things that I do because if you're doing it the right way, you don't necessarily need it. But if you're going to do atherectomy where you're actually removing calcium, then you have to use something to catch. The other thing is, if you knocked off a chunk of calcium, we have aspiration catheters, like a catheter with a little vacuum that you put in, you could aspirate that out. I guess the danger is when you do atherectomy and you grind up this calcium, it's really fine, like dust. It can go into really, really tiny vessels in the toes, and then you can't take a catheter all the way down there. So you really need to use that protective basket or whatever. Okay, so I have this is a case that I saw when I think it was like August of my fellowship year. So I was like really early. And so it was an 89-year-old. She came in with this cold, pulseless, cyanotic leg. So what are you guys thinking about here, maybe? Thinking about something chronic or acute? Yeah, definitely more acute. And then we're thinking about those like 6 Ps, right? Like cold, pulseless. So I remember I got called from the ER at like midnight or 11 p.m. or something. And I went in to see this lady, and she had this history of AFib on anticoagulation. So I was already kind of thinking maybe she threw a clot. She had a history of malignancy. So we know that malignancy is something that can make patients more likely to develop clots. And she wasn't on chemotherapy or anything at the time. She had dementia, so this was like already, I thought, going to be maybe an issue for getting a consent for a procedure. Like I didn't know how consentable she was and how good the history was going to be from her, but luckily she had her daughter with her, and she had a prior history of DVT. So I'm already thinking like, okay, she has a lot of reasons why she'd be having clot, and she's had a history of clotting on the venous side. And then knowing that she's AFib, kind of question like, is this patient compliant with their medication? Did she stop taking it? Like, what's going on? So these are some of the things I was thinking about when I went to go see her. So when I saw her, from a vital standpoint, she looked good, but she was drowsy. And this is what she looked like. So on the left side, she had this asymmetric swelling and coolness. Her leg was cold all from mid-thigh all the way down to her feet. She wasn't able to really feel where I was like touching her. Like I was like, can you feel me touching here? She couldn't feel any of that. And she was unable to move her toes. So then I also Dopplered her, and I couldn't get any, I palpated, I couldn't feel her pulses, and I couldn't get Doppler signals in her feet. I know this is covered, but
Both feet or?
just the left side. Yeah, good question. So this is all just for the left lower extremity. So the right side was totally normal. She's able to move it. She could feel, she had pulses, but on this side, totally abnormal. So here, go ahead.
Where's the swelling coming from? I mean, if you're not delivering blood arterial,
Yeah.
is it like a common venous insufficiency?
Sometimes, but it's like an inflammatory reaction too. So they start to develop swelling very quickly.
Especially if they're like getting tissue necrosis.
Yeah, exactly. And if this isn't chronic and they don't have collateral supply, then they're going to start getting like lactic acid and all these like inflammatory mediators building up that's going to cause tissue swelling. So at this point, when I saw her, I'm thinking like, we're at this point where she has some sensory loss and she didn't have audible arterial Dopplers. So I was actually worried, that we're getting to the point where she's like at Rutherford 2B, verging on 3. And remember we talked about 3 being a surgical emergency. So I just remember, like, this is August of my fellowship year. It's like I'm early on. And I remember the program director was attending on call with me. And I was like, I have to decide if I'm going to call him in at like midnight to do this case. And I ended up so first, before I decided to do that, she'd actually come with an ultrasound. And the techs that we had at Miami were really great. They would draw This is like idiot proof. So you could tell where they were like, there's no flow here in the left leg, and they could see a clot from the common femoral all the way down. And then this is what the duplex imaging looked like here. So this is the left common femoral artery. There's no flow. This is the artery right here. There's no flow. This is the left popliteal vein. There's no flow here, no flow in the SFA, and they're not seeing any flow distally. So this is an acutely threatened leg. And we know, she already has sensory loss and she's not able to move her toes. So this is getting pretty serious. So I put her in this category and I ended up calling my attending in. And when you're thinking about treating, so I was like, we're going to treat this patient. I'm going to bring the team in. There's multiple ways to treat acute limb ischemia. So you can do lysis, which is where you put a catheter into the artery and you drip TPA. The only thing with lysis is it's great for dissolving distal clot because you're dripping that medication in over time, but you have to lyse these patients for 24 hours. So if this is a patient that's going to, that we're worried is progressing to a surgical emergency, I'm not going to lyse her for 24 hours. I need to like open up that artery immediately. So I kind of, didn't put lysis on my, I guess, treatment options. Otherwise, we can do thrombectomy. So you can aspirate. This is a catheter that's basically like a shop vacuum, like it's a hose that can aspirate out the clot. Or you can do mechanical thrombectomy, which is a catheter that may have something that grabs the clot and pulls it out. So either a vacuum or something that actually pulls out the clot. Or you can do surgery. And obviously I didn't want to send her to surgery. Like I wanted to treat the patient. So, and then when you're doing a procedure, sometimes there's a lot of momentum to bring the patient in. You're like, this is emergency. I have to do all these things. You have to remember, like, there are other things, like the patient could have a severe contrast allergy and they could be anaphylactic. So you don't want to bring this patient in and save their leg and then kill the patient because you gave them contrast and you didn't treat them for their contrast allergy. So typical pre-medication for a contrast allergy is 12 hours. But in an emergency, you can give a big dose of Solumedrol and Benadryl and bring the patient to IR.
That to see if they have a contrast allergy? Or
Just see if
it.
This is like if they have a documented history. So just make sure you look in the chart or like ask them if they've had any issues with contrast before.
And if it's not documented, you
just assume there isn't, and you're like, I'm gonna take him back and blast him. Exactly. And then consent's obviously a big deal with this demented patient. She wasn't really consentable. I had to like have her daughter was luckily already her medical, like legal representative. So I was able to get consent quickly, but this can be a real, like in real life can be a real pain. Like in an emergent situation, you can get a 2-physician emergent consent. And this was kind of verging on an emergent situation, but just something to keep in mind. All right, so now the interesting part. So we got her, all of her clot was on her left side, remember? So we went on the right. This is the right common femoral artery here. This is the superficial femoral artery in the profunda. So we access the right common femoral artery, and here's an angiogram. So you see the right common iliac, the left common iliac, and the aorta. This is all open. And then we look at, so this is the right side again, right common, left common. And the hardest thing sometimes to see is something that isn't there. To see the external iliac on the right side, you don't see that vessel on the left. So the whole external iliac is gone. This is the internal iliac here. So here's where the external iliac would come off, and that's totally out. And then it's just showing you what we're missing here is this vessel here. Oh, my arrow's off. Okay. All right, so we got a wire up into the aorta and down into the external iliac. This is all full of soft clot, so we're able to kind of twiddle our wire through. When it's something chronic and like heavily calcified, the wire is not going to go as easily, but when it's fresh clot and an acute presentation like this, the wire goes pretty easily. So even though you don't see any filling of the vessel here, we're able to get our wire and our catheter down. This image where it's white is a road map. So this is like from the prior angiogram. We use that to kind of give us an idea of where the vessel is. So we're not putting our wire like somewhere out here in no man's land. Okay, so then we bring up this hose catheter, which is an aspiration catheter, and we bring it down into the external iliac artery. And I hope that some of these play, maybe not. Maybe I can like show you on here. Let's see. Okay, well, some of these are videos. Okay, there we go. So this is how we like move the catheter into the vessel. So this is actually hooked up to something that's sucking on the back of this, and it's aspirating clot. And you're just moving it back and forth. And that was an 8 French catheter, and we were noticing that we weren't getting anything out. So we thought maybe the clot's even bigger, because the common iliac artery is a pretty big vessel. So we went ahead and put in a larger catheter, which is a 12 French catheter. And I don't know. So we put this in over a wire, and this is the Cat 12. This is a 12 French catheter. Let's see if I can get it to. Maybe this isn't the video.
Next slide.
Yeah, thanks. No. What's going on? Okay, that's fine. Okay, so then we brought this 12 French catheter down, and you can see you can take this big catheter in deep down into the vessels, and then this is hooked up to what we call a lightning aspiration system. So this doesn't just keep sucking blood out while you exsanguinate the patient. What it does is it has a chip that recognizes that you're in free-flowing blood. So it'll shut off the aspiration when you're in blood. And then it turns on the aspiration when the catheter is embedded in clot. So you don't just, because if you just hooked up a hose into someone's artery, you could bleed them to death. So that's why this is kind of interesting, because it doesn't rely on you, because you're operating the catheter and looking at the fluoro. You're not necessarily looking at what's being aspirated out. And what you can do is you hear this like audible clicking noise, and that clicking noise tells you that you're embedded in clot. And then when it turns off, you know that you are in like free flowing blood. And so all the blood gets filtered through. So here's like the catheter. When it's embedded in clot, it aspirates it and it gets filtered through this basket. So whatever blood you aspirate comes down here, and then the clot stays up here. And so here's us like, we're moving the catheter back and forth, trying to clean out that artery. And we're like listening to see like, am I exsanguinating the patient, or am I really aspirating clot out? And then we took it back up into the external iliac. We were all the way down into the superficial femoral. And now, remember, we didn't see this vessel at all before, and now we're seeing blood flow here. So you see how clean this vessel is? It's not ratty, like it has calcium in it. This was all fresh clot that's now been aspirated out. And then this is a superficial femoral artery that we cleaned out, and that looks great too. And then down into her popliteal and into her foot. So she has blood flow into her foot too. And this is the actual clot that we took out. And the text will like lay it out nicely for you so you can see. So we took out this huge piece of clot, and everybody likes to see clot. That was a large volume there. And then this is what she looked like the next morning. So like we ended up finishing around like 3 a.m. And then when I went back to see her at like 7 a.m., this is what she looked like. So, and that's really it. This is just another review over AOI.
Sorry, can you go back to the recording and show them a couple like of the pictures, just because it won't show up on there?
Oh yeah.
Yeah.
Let me see.
I know the Andy doesn't play, but
Okay. So here's
just yeah,
Yeah. Okay, so here's where we use that 8 French sheath, and then, is it playing? Oh yeah, dang, I could have done mine here. So when we were moving this catheter up and down, it was getting clogged, and we thought the clot was too big. So we went ahead and upgraded that to a 12 French catheter. And this is that 12 French Cat 12. And then this is the lightning aspiration system. So this is a system that tells you whether or not you're embedded in clot or you're in free flowing blood. And this is kind of what it looks like. The blood gets filtered through, the clot stays in the basket. And then here's the catheter moving up and down.
What's the advantage of starting off with a smaller size catheter?
That's a good question. So when you use an 8 French catheter, you can use a standard closure device like an angioseal, which is something that we're really used to using. When you put in something as big as a 12 French, then you either have to think about having someone from surgery close it, or you have to use something called per close, and you have to put 2 per close devices in to close the artery, because now you've made a really big hole in the artery. So it's kind of like operator dependent. It's like on your comfort level. I mean, the idea is like you want to stay as small as possible. If you don't have to put a giant hole in the artery, then that's what you want to do. And we were thinking that this was mostly common femoral clot and below, because that's what it looked like on the ultrasound. But I think what happened is that the tech couldn't see up high into the external iliac. They weren't able to ultrasound high and show that clot in the pelvis, and that's a much bigger vessel. So when we knew that there was clot all the way up there, we're like, this smaller catheter isn't getting all of it. Like the clot is so big that when it's trying to aspirate, the catheter is just getting clogged because we weren't getting anything. And so then we knew we had to upgrade to, or upsize. And this is the largest size aspiration catheter for arterial.
So let's say you put in like 12 French. I mean, I don't know what size it goes up to, but let's say you weren't getting anything there. Would you try to do something like a clot trigger, like send down like a?
So that's a good question. The clot trigger is for venous,
Okay.
and it's a really big device. It's like 16 to 24 French, and you would not put that into an artery. If we weren't getting anything with the 12 French, which I think that would be unlikely, because I think for the external iliac, that's a pretty good size. If I wasn't getting anything with that, then she might have to go to surgery. That's the thing at that point, if we weren't able to get anything, or, if she was salvageable, I would have done lysis.
What does it mean going to surgery?
That means that she's going to have a procedure where they open up the blood vessel and take out the clot, and they do an embolectomy. And you want to obviously avoid sending a patient where they have to have a surgical incision and they open up a blood vessel and scoop out the clot if you can just make a tiny nick in the groin. Yeah. But sometimes they have to do that, if we can't get it. And the other thing that they can do is they can open up the blood vessel and put down a Fogarty catheter, a balloon catheter, and they can pull the clot out. But, they've already opened up the vessel, so they can just scoop that out. It's not going to come through, a small catheter.
So how long did this procedure take you from start to finish?
About an hour and a half, 2 hours. Yeah. I think because, we tried with the smaller catheter and then we had to upsize, and that means that we have to upsize the sheath, because the sheath that we used was an 8 French sheath. So when we move up to a 12 French, we have to pre-close the groin, meaning we put those closure devices in the beginning. And then we upsize the sheath to a 12 French sheath, then put this larger catheter in. So that adds time. Yeah. But when we bring this patient into the room, we've already started heparinizing, we started giving heparin. So we're doing things that are helping not propagate more clot. Because if we just left her without giving her heparin and stuff like that, then it's just going to get worse and worse and worse.
So what was the time frame from when she presented, I guess, to the ED
to when we got her in the room?
Procedure?
I think so. I saw her around 11 or 12, and we were in the room by 1:32. It was fast. But that's because I was like, we need to do this right now. And so that's the thing. When you see a patient like this, it's an emergency because if she developed paresthesias, then it's irreversible. And you're talking about an amputation. And this isn't a small amputation. This is like a big time above the knee amputation based on where her clot is. So I remember like it was August and I was like, do I call in my program director in the middle of the night? But then I was like, I mean, I think so, because otherwise this lady's going to lose her leg, you know? So your suspicion has to be really high. Yeah. Oh, we're out of time. Okay. I had like a chronic case too, but I'll save that for next time.
It's up to you. I mean, it is up to them as well. I don't know.
It's on a different PowerPoint anyway,
Oh.
so don't worry about it. Okay. But yeah. But this was like, it was definitely a rewarding case. Like when we saw this, I remember like my program director was like, dude, we just saved her leg. It was awesome. And then, you know, just seeing what she looked like, you know, afterwards.
Yeah, I think the picture a few hours later is pretty competitive.
Yeah.
Pretty cool.
This picture.
So kind of leading off to that, can you speak to like the use of IR and then kind of these minimally invasive procedures for saving with like chronic PAD? I mean, especially in the South,
Yeah.
you see a lot of BKAs, a lot of amputations.
So, you know, when we start to see patients that have gangrene, or they're developing some sort of small non-healing ulcer, you want to do everything you can, because if you don't, they're going to lose their limb. Like it's going to become a toe amputation or a show part, or, you know, like a foot or whatever. And once a patient has an amputation, their quality of life like really tanks. Their mobility changes, you know, once they have a below the knee or above the knee amputation, the way that they weight bear, or, you know, even sit in a bed or move around, like all of that changes. So when you start to see patients that are referred to you and they have gangrene or they have like non-healing wounds, the idea should be like, I'm going to do everything I can to save the leg and hopefully not make it worse, you know. But it's always, the discussion with the patient is always, the risks of this procedure are that I could make this a lot worse. But if I don't do anything, you're going to get an amputation. So you know, it's kind of like a difficult situation to be in. And when there's a ton of different tools to use for chronic limb ischemia, like when I was talking about with acute, the things that we do are we drip TPA, or we do aspiration or mechanical thrombectomy. So we're like sucking the clot out or we're removing it. We have to do something that takes it out quickly because this is fresh clot. With chronic, these are people that have really calcified vessels that built up over time. And so you're not going to really like suck out something because it's chronic, it's calcified. So what you can do is you can do angioplasty, which is you balloon the vessel, and there's specialized balloons. You can just do a plain balloon. There's balloons that are cutting balloons that they cause cracks in the calcium. There's drug-coated balloons, so they have a medicine on them, and it's like an antiplatelet medication, and that prolongs the patency of the vessel. So that's just angioplasty alone. Or you can do, you can stent the vessel. So usually my algorithm is when I see a patient that is developing a wound, I usually like to cross whatever lesion they have, and I'll try to angioplasty it with a balloon, a drug-coated balloon, some sort of specialized balloon. And I don't stent unless I really have to, because you don't want to drop stents and then like later you come back, the stent goes down. You want to like minimize the amount of like foreign stuff you put in patients as long as you can. But if it's like you've angioplasted them and the vessel doesn't look any better, then you're like, I'm going to have to stent them to keep it open because I have to do everything I can to keep this vessel open. And there's specialized stents. There's plain stents, and then there's drug-coated stents. So they have the same kind of drug coating that those balloons have. And so those were some of the tools that we use. But
Understandable, it's a big deal. It's not I think South Carolina has like some of the worst amputation rates.
Yeah.
So
Let me see if I can just show you. I have like a, I'll just show you this quick case. So this is like an old talk that I gave. I wonder, can I do presentation mode on here? Okay, so, oh no, not my PE case. Sorry, wrong one. Here it is. Oh, I can't just view it on here. Why is everything so difficult? So one of the types of balloons that we have is a lithoplasty balloon. So have you heard of like lithotripsy for kidney stones? It's the same technology in a balloon. So it like uses that sonic pressure wave to crack the calcium. And it doesn't crack, it doesn't like cause it to go distally or get removed like the way we talked about atherectomy, but it kind of softens the calcium. So there, I have a case of a patient with chronic limb ischemia that I did a lithoplasty on, which I don't know if we're going to get to see. Let's see, maybe I can just download it real quick. If you guys need to go, that's fine. I'll show you this quickly. All right. So this was something I showed for a conference. So this was a guy with a non-healing ulcer. So he had a right lower extremity non-healing ulcer, and he had history of prior DVT and prior left foot amputations. He was on Lipitor, and he's on blood pressure medication. So this is his non-healing wound here. And on the Rutherford classification, he's minor tissue loss. This is the non-invasive imaging we got. So this is looking at, you know, when we talked about measuring angular brachial indices, we also look at the pulse volume recordings or the pressure recordings in the leg. So this is the left leg and this is the right leg. And see how this is waveform is dampened compared to the other side. And in the foot, the right foot, the waveforms are all flat compared to the left. So this is normal and this is abnormal. I'm just going to go quickly through this. So on the right side in his superficial femoral artery, he has that normal triphasic waveform. But when you get down into the popliteal, the waveform is really flat. Okay, this is not a normal arterial waveform. And here's a duplex just showing you a minimal flow in that popliteal artery. And then he has some blockage in the vessels down here. So we had a CTA showing on the right side. As we move down the SFA, he's got really calcified popliteal artery here. And this is just a still image of how, so this is the calcium here, and then this is the entire artery. So the lumen is very small. So he had right lower extremity wounds. He has like femoral popliteal disease. Remember we talked about that being that segment in the thigh and the knee. And then his popliteal artery was very calcified. So these are some of the things I talked about. So when you're treating chronic limb ischemia, you can do angioplasty. So ballooning with a plain balloon or something that has a medication coated on it. You can do specialized angioplasty, so scoring balloons or cutting balloons where they cut into the calcium, or lithoplasty. You can stent. You can do atherectomy where you shave off the calcium, or endarterectomy, which is a surgical procedure where they open up the vessel and they scoop out the calcium in the vessel. And this is what, so here's a superficial femoral artery. It's open on the right side. But here's this calcium in the popliteal artery. So see, here's an SFA, superficial femoral artery, and then you don't see contrast here. So there's big rocky calcium in the popliteal artery. And then below the knee, he has some blood flow going down into the tibial vessels. So one of the things we look at is, can we go from the foot and take a wire all the way up backwards and open up the vessel that way? But he didn't really have a good target here. And the idea we were thinking is, he has a non-healing wound, so we just need to improve blood flow to the foot. We need to do whatever we can to improve blood flow here. And we thought the best way to do it was treating that calcified lesion in the popliteal artery. So here it is again. And these are just images showing how you have to be really careful when you twiddle the wire through this lesion, because you want to make sure you're not just dissecting the vessel and you're actually going into the true lumen. So you do that by, like, you know, just very carefully twiddling. It's like a feel, you know, when you're in the right space, and you know very quickly when you've done something wrong to the vessel. And then once you cross this lesion here, then you're like, okay, now I have a wire across here. I can put a balloon over this and treat it. So that's the idea with the chronic thing. But something that's acute, you know, you're putting an aspiration catheter and you're taking it out. With something chronic, you have to cross it and then be in a position to treat. And then we do an angiogram just to show that we're really in the vessel. This is the lithoplasty device. So this is, the balloon is like just like any other angioplasty balloon, but it has these transmitters that emit sonic pressure waves, and they get transmitted through the intima and the medium in the calcium, or intima and media in the vessel wall, and it fractures the calcium. So that's how this balloon works. So that's what we did here. We brought this balloon, here's the balloon here, and you can see some waste. There's a waste here in the balloon, so that's some narrowing in the vessel. And then afterwards, you can see the difference. And then this is just further down the leg, some improved blood flow down into the tibial vessels compared to before. So we thought, you know, are we done here, or should we treat with something else? We ended up sort of debating, should we go back in and also use a drug-coated balloon? You know, it looked pretty good, but the thing is, with these patients, you want to do everything you can to make sure that you've optimized blood flow, because otherwise this patient's getting an amputation. So we decided, you know, we're like, it looks pretty good. We think it could be better. So we went back in and we used a drug-coated balloon, and it's coated with paclitaxel, and we angioplastied that same area that we treated with a 5mm drug-coated balloon. And now you can see some improved blood flow to the foot. So this is one of the things that we did at Miami, is we had perfusion imaging. So it looks at the time, it's like time to flight of blood to the foot. So this is pre and this is post in the same amount of time. And you can see objectively that there's much better blood flow to the foot. And this is what, you know, we started with and what we ended with. So, I ended up seeing that patient a couple months later in clinic, and his wound was healing. I should have had a picture of that. That would have been better, I'm realizing. But anyway, that's just sort of a very quick example of how I would treat a chronic lesion.
What do you do if you accidentally dissect that's nipples?
Then that's a good question, because that happens. So you make the decision of, is this a flow limiting dissection? Meaning, is this dissection so bad that we're not getting any blood flow to the rest of the leg? If it's not, then usually these things resolve on their own. You can just put the patient on heparin and watch them, and it'll go away on its own. If it's flow limiting, like that means that you've dissected the wall so much that now the blood isn't getting to the rest of the leg, then you need to put a stent in. Yeah, so you have to make sure you put a stent into the true lumen of the vessel, and then you tack up the dissection.
Why would you?
Because when you have a dissection that's not flow limiting, meaning there's still blood flow, there's still some altered hemodynamics in the blood flow. So the blood flow could be going a little slower. You just want to make sure it doesn't clot and cause like a thrombus or an embolus. So that's why you keep the patient on heparin.
That doesn't interfere with disabilities.
No. Yeah, I know it seems kind of weird, but most of the time, like 90% of the time when we cause dissections, we don't do anything. We give the patient a little bit of heparin and it resolves on its own. But the important thing is, like, when you're in the case and you see a dissection, you have to make sure, is there flow distally? Like, is there flow still going to the foot or wherever? I mean, Yesterday I was doing a splenic artery aneurysm embolization case, and we actually dissected her celiac artery. This is an 87-year-old. Her vessels are like, very prone to dissection, but we injected and we're like, oh, it looks fine. Like there's still blood flow going to the splenic, there's still blood flow going to her hepatic arteries. So even though she had a dissection in the celiac, we didn't do anything. We just monitored her, she's fine. So you don't want to stent unless you have to, because anytime you put something foreign in a patient, there's a risk that the stent can go down or whatever, and then it's like you have to go back in and open up the stent. So it's better if you can just let it heal on its own. But that's not always the case. If you've dissected the vessels so badly that they're not getting full, then you have to stent.